Hey, welcome. This is our Pain Science Day. This is literally one of my most favorite topics ever, and I definitely feel like it shifted when I learned more in depth about how pain works in the body. It completely shifted how I work with people, in my opinion, for the better. So I'm really excited to share this content, and we're gonna start with an inquiry and we'll break out into small groups and you'll discuss it in small groups and then we'll come into the big group and discuss. And so the inquiry is, what is an injury? What is
Diana, there's 18 people. How many breakout rooms do you want, or how many?
let's just do groups of two, so just pairs. Yeah.
Okay,
And if you're watching the recording, just contemplate, what is an injury? And maybe even ask somebody that you know what they think.
nice idea.
Yeah.
How long do they have, Diana?
We're just gonna do like 2 or 3 minutes short. So, would anyone like to volunteer their definition or what they gained some insight from as far as what is an injury? Any good ones?
I'll volunteer.
Thank you, Trisha.
Uh, we said it was anything that would impair your usual capacity to function. So that could be a physical thing like, twisting your ankle. It could be a mental thing like, I can't do this, or a spiritual, emotional injury.
Yeah, I love that, so that you went like bigger, like it could be physical, but emotional and spiritual count as well. It's anything that disrupts your normal capacity. Yeah, like that. I'm seeing some in the chat. Disruption of energy in the brain body. Any disruption. Um, oh, well, we have oh, you can Google Waking Womb to find her website. I feel like that was probably a side conversation, but highly recommend Veronica. Um, Anything that keeps you from living life to the fullest. That's an interesting one. Yeah.
Mm,
Anything that keeps you from living life to the fullest is an injury. Very possible. Something that causes pain, also an interesting one, right? And I love this because it's like, well, crap. Like we use this word all the time. Like, oh, I have an injury. I have a little injury. What is it? Something that induces a trauma response in the brain or body. Yeah, there's really no universal definition of what it is. And I find that very interesting. I love how you all are thinking really broadly, and I'm like, oh, this is like great. Because to me, like, since there is no formal definition or no universal definition, often people will say, oh, like, if you have a tear in your rotator cuff, or if you've sprained your ankle, or if you've broken your arm, I've injured my arm, like which is true. And sometimes people who have injury don't, like, it doesn't disrupt their life. So if somebody has a rotator cuff tear, but they're able to do whatever they want to do, is it really considered an injury? And it's just really, the answer is it depends on all the context. So I'm going to share my screen and we're going to get into it. So, what is an injury? Well, we don't really know. There's no exact definition. There's a lot of things it depends on. This is a slide that I think by the end of today's session, I think you're going to really be able to understand this slide in a more nuanced, deep way. And so I'm going to introduce this term. Maybe you've heard of it before, nociception. So it's one of the neuroreceptors that we all have. And nociceptors are threat receptors. They are not pain receptors. And in most books, texts, even semi-recent ones, you will see an image like this describing nociception. And sometimes it's wrong. They'll say, you know, pain stimulus comes into the body and it goes up to the brain. But actually, there's no such thing as a pain receptor in the body. The pain receptors don't exist. Nociceptors exist, and nociception is threat receptors. That's more of the modern understanding. So these receptors go up to our brain, and our brain is going to decide if the potential threat is deserving of pain. So we say pain is an output of the brain. It's a decision made by the brain in this three-part loop, right? The inputs come in, the brain decides something, and the brain creates an output in this continuous loop. So nociception would be an input. The brain decides, is that threat dangerous? And if it is, it might produce an output of pain, because pain is a behavior modification tool that the brain uses to help keep us safer. Pain is going to change how we move. It's going to change how we walk through the world. It's going to change our behavior. So the idea is that if there's a potential threat, our brain has mechanisms to get us to change what we're doing to help protect us, to keep us safe for the next few moments. Um, so I'm gonna share. I'm laughing at my images that I created. I think they're hilarious. I'm gonna share a story, and it's a tale of two nails. And these stories are shared. I got them from Dr. Rachel Zoffness. She's an American pain psychologist and author. She's an assistant clinical professor at the UCSF School of Medicine and also lectures at Stanford. And she's just like a thought leader in the pain science world. And she shares these stories to get us thinking about pain. So, story one is a man. These are true stories. Okay, these are true stories that happened. So, case studies, if you will. So, there was a guy and he was a construction worker, and he was on site, and I don't know if he fell off a ladder or jumped down from a ladder, but let's say he jumped down and he landed on a nail, and the nail went straight through his work boot, clear to the side. And he had this, I mean, as we know about the homunculus and how delicate the feet are, like he experienced a tremendous amount of pain. Everybody on site was like concerned and had to rush him to the hospital, and he was in such searing pain they had to give him like a high amount of pain medication so that he would be still enough so they could cut off his boot. And when they cut off his boot, they discovered the nail miraculously went in between his toes, and he literally didn't have a scratch on his foot. So there was zero tissue damage. The nail did not hurt his physical body, yet he experienced this incredible amount of pain to the point where he was rushed to the ER and given pain medication. Um, so pause that story. Well, I guess what we can say is that pain is not directly related to tissue damage, but there's more, like the brain is receiving all the information and deciding how dangerous of a situation it is. So the brain was like, we can't just sit here. We have a nail through our foot. Let's go. Okay. Second story. Another construction worker. So the joke is construction workers have a very dangerous job. But another construction worker was working with a nail gun, and when he was putting the nails in the wood or something, there was a little glitch with the nail gun, and the nail gun knocked back and like ricocheted and kind of hit him in his jaw, and the nail sort of flew out and bounced on the ground. And he was a bit stunned and a little bit shocked, but he was like, okay, just collected himself and continued working for the rest of the day, went home, ate dinner, went to work the next day. And I think it was like a couple days later, he still had this very subtle ache in his jaw that he went to the doctor, got an x-ray, and the nail was embedded in his jaw. It did not, in fact, ricochet off like he thought it did. It was actually embedded into his jaw. So, pretty significant tissue damage, but not a lot of pain associated with it. So these stories that Dr. Rachel Zoffness share are just this kind of extreme examples, but real examples of how pain is not really about tissue damage. It's more complex than that. Tissue damage, of course, plays a huge part of it, but it's not the only consideration. This is an image. This is in your work in the manual that we gave, and this graph comes from a meta-analysis of over 30 different studies, and they were looking at tissue damage and pain. And so low back pain, of course, is like one of the highest complaints in the US, at least, maybe the world, I can't remember, but a lot of people have low back pain, and it's gotten a lot of studies done, like what causes so much low back pain. And so this is a graph where they were looking at different kinds of specific kinds of low back pain, from disc degeneration, disc signal loss, the height of the disc shortening, bulging discs, protrusions, fissures, the facet degeneration, which is where um like the little bones that come through, so like a lot more pinched nerves could be there, or even spondylolisthesis. So a huge list of pretty significant tissue damage. And then you can see across the ages, 20-year-olds, 30-year-olds, 40-year-olds, 50, 60, 70, 80-year-olds. So these percentages are the percentage of people that were found to have this specific tissue damage, right? So at 20 years old, 30% of the people in this meta-analysis had disc degeneration. 96% of the people had disc degeneration in their 80s. And what's really important about this graph is that these are asymptomatic patients.
Hmm.
These people don't have any pain symptoms, no loss of function, didn't even know maybe they had it. So, why I'm hammering this in is because, especially for movement professionals, I'm actually going to stop my screen share because I want to see our faces here. When I was a yoga teacher, one of the first things that I learned, especially around sequencing and this and that, is like safety. Like, you want to keep people safe. You don't want to hurt people. And I completely agree with that. And what do you do if somebody has an injury who comes in? And there's this fear that I experienced as I was becoming a movement teacher, that like injuries are really scary. If somebody has an injury, um, I'm now really scared, and maybe I need to change my whole class or like modify so that they don't hurt themselves more. And it's a huge amount of pressure for yoga teachers. Like, I'm not a doctor, I'm not a physical therapist, and we experience a huge amount of pressure teaching people how to move their bodies. And what I love about this understanding is not to be like, oh, you have an injury, who cares? Let's just do whatever. But it's to give us a little bit of some breathing room, that just because you have an injury doesn't mean you're going to experience pain. And just because you're in pain doesn't necessarily mean you have an injury. So, right there, I can begin to not just give people fear, like, oh, you have injury. well, you shouldn't do this, this, or this because I don't want you to hurt more.
Hmm.
That's not necessarily true or accurate. And as we go later into this lecture and explore some of the other concepts, we can really begin to see like sometimes giving people fear about their injuries is going to make them hurt more.
Mhm.
Right? Inducing unnecessary fear can create more pain in people's experience. And so when we learn about how pain works, we can have a stronger sense of how to work with people, to not be so scared working, even if they have pain or injuries. Like it, we can give ourselves a little bit of a break. Yes, still be responsible and attuned, but I'm hoping this lecture decreases your fear as movement professionals working with people who have pain and injury, which in my opinion is most people, right? So this is also not to say, one little side note here, if you have an acute injury, and by acute, I mean it just happened, like I just broke my wrist. Okay, probably you're not going to be putting a lot of weight on your wrist, like doing planks and handstands right away. Like there is with acute injuries, 3 months or less, like there's usually a protocol for healing that they're usually working with their doctors on. Chronic pain is pain that lasts longer than the quote unquote normal healing time. So any pain that lasts longer than 3 months is considered chronic. So let's say this is an anecdote from one of my students. I've shared this before, so if you've heard this, please just hear it again. I had a woman, she was taking my yoga classes and she after a few months, like I would watch her and she has a pretty strong practice, does great like her down dogs and chaturangas and her form was pretty good. And one day after several months of her coming to my class regularly, we I was gonna teach handstands at the wall, and I moved people to the wall, and I see her sitting there while everyone else is going. And normally she's like quite participatory in the class, so I knew it was strange. So I just approached her. I was like, "Hey, like what's going on?" And she's like, "Oh, well, I have an injury in my shoulder." And I was like, "Oh, like what injury do you have in your shoulder?" And she was like, "Oh, well, I like broke it 10 years ago, so I don't do handstands." And meanwhile, I'm like, "Okay, 10 years ago she broke her shoulder. I've seen her down dog. I've seen her planks. Like there's I was like, "Oh, she has a story that she gathered from 10 years ago that's like, oh, I broke my shoulder. I don't do this now." And that story has prevented her from doing handstands. I was like, well, and so I asked, I was like, I was like, I've seen your down dog. I think you can do it. Would you like me to spot you into it? Would you be open to try it? And she was like, oh, sure, I'll try. I helped her into it. She got into handstand and she was just elated. And I don't really care about handstands, but what was really cool is that she did something for the first time in 10 years that she had no idea she could do. And
Hmm.
that's part of what we get to do as movement teachers, and especially when we have greater knowledge and a greater landing in some of how these systems work. It's like we get to help people do things that maybe they don't think they can do. And I think that's really awesome. Had she said, I don't really want to try handstand, great, moving on. I don't care if you do handstand or not. Um, okay.
May I just add another thing that I feel that what you've just talked about is really beneficial for us as teachers, depending on the kind of teacher you are. But if you came from maybe an Iyengar background, where often we're supposed to use postures to deal with specific issues, and there's a sort of claim that specific postures can fix certain things, which is a whole other discussion. But as a teacher, I used to feel a pressure when someone would come in with some kind of pain that I should know what was causing the pain. So I would need to know, okay, well, that's rotator cuff, or that's tennis elbow, or that's XYZ. And actually, that pressure was massive because very often people didn't have a diagnosis from a doctor. They'd been to multiple practitioners, and I was trying to magically be the one that would have the right answer. But actually, with what Diana's talking about, it gives another reason to, in a way, not need to have the diagnostic answer. You're dealing with actually what's in front of you in terms of the individual's experience rather than what may or may not actually be wrong.
Yeah, thank you. So I just have one more slide I'm going to share before I turn this over to Neve briefly, which is this is sort of the new, maybe you've heard of this or have seen this. As far as in the pain science world, largely, and I would say in the past 10, 15, 20 years, we are now in this model of pain science, the biopsychosocial. In the past, most of pain science has been what's called a biomedical model, which is your biology causes pain. Like if you have tissue damage, then that's what's causing your pain. And that was really the cornerstone of how people were treated. If you have a rotator cuff injury, then that's what's causing your shoulder pain, and that's what we'll treat. But now, with this more broad, full body, full neurology understanding of pain, it's now called the biopsychosocial model of pain. So, yes, your biology does contribute to your pain experience, like the nociceptors that are coming in from tissue being damaged. But there's also a psychological component. What do you think about pain? How is your psychology doing about it? Like, what are your beliefs about pain or your situation? And there's also social component to it. There's a lot of studies that show when you have greater social supports, you experience less pain. So there's a huge social component to pain. So this is a more holistic understanding of what we know and what contributes to our pain experience. Biopsychosocial. So I'm going to pass this to Neve as we get a little more into some of the nitty gritty about pain theories.
I'm interested in that social piece, Diana, as well as social support and people with more social support having a lower experience of pain. I'm also interested in the social expectation of pain. So if we're told that, for example, labor should feel this painful, then maybe it's more likely to feel that painful. Whereas if somebody else tells us, those kind of things I think are really interesting. Is that you putting up your hand, Miriam?
If you don't mind if I make just two comments on it, just briefly. One, I appreciate what you said about somebody coming into your class, but it doesn't matter. If somebody feels pain, you can't not legitimize that feeling, whether it's real, imagined, or whatever. So I think as a yoga teacher, you have to be, or any kind of person, you have to be very careful in terms of, and the other thing is I grew up in a generation where doctors thought every woman's pain was in her head. And so it's striking the balance between physical pain that is there and how it's dealt with. Does that make sense?
Yeah, I'm so glad you brought that up. So if I didn't make that clear, thank you, thank you, thank you. Your pain is real. If somebody says they're in pain, 100% they are in pain. They're often not making it up. So as what I hope this lecture can bring us as movement professionals is just a little less fear in working with them. Yes, they are in pain. Their pain is 100% real. I've never once made up pain. Like I usually am feeling it. There might not be tissue damage, but the experience of pain is real and felt in your body, 100%. And as teachers, we want to acknowledge that for sure and be sensitive to it. And in the back of our minds, we can also hopefully we'll be going over some tools on how to think about this and approach this to really help people. And I never think it's a good idea to invalidate somebody's experience. Like, oh, like that's in your head. So thank you for bringing that up. It's super important. Yes,
Trisha.
Trisha and Brandy, and then we will move on.
I want to be real quick, but I come from a psychotherapy background. So there's two parts of pain that are, applicable here. One is our environment can actually reinforce pain, real pain. I'm not saying anybody doesn't have any pain, but if you think of like a 2-year-old toddling down the sidewalk and they fall down and you go, ah, and you run over to them and then they feel upset by that. And that, or you got a 2-year-old, like my kids are big and grown, but when there was a neighbor kid and he would run down the sidewalk, crash to the ground, blood running down his legs, he'd get up and say, brush it off to himself and keep on going. So we have to think about how our environment contributes to our pain. So, maybe my husband pays more attention to me if I say I'm in pain, and I need that for an emotion in an emotional way that contributes to my continuing to have pain. That was the first thing. The second thing, in terms of education as a yoga teacher or anyone, is that sometimes we have a message in our mind that if we're in pain, movement is bad. And sometimes, like when you have an acute injury, it's best to let that part rest. But if we continue to let that part rest, then we restrict blood flow and oxygen and everything that needs to happen to make that be mobile. So sometimes it's good to be able to educate people that, you go at your pace and you're in your body, I'm not. And movement is not always bad for you when you're in pain. Sometimes it's actually good.
Yeah.
That's all.
Yeah. Thank you.
Brandy?
Hi. I'm loving this discussion because I think about pain a lot because I work one-on-one with many people, sometimes in the yoga capacity, but also I'm an energy worker. So I'm working oftentimes in table sessions and working with people with chronic pain, oftentimes. And so I guess what I want to sort of just bring into the conversation to sort of get your opinions on is sort of this spiritual aspect to pain. Because what I see when I'm working with people is oftentimes there's something that they're not conscious of mentally. It is a repressed spiritual, psycho-spiritual, or sometimes something like dimensional, like related to like a past life or something like this for those of you who are into that kind of thing. But oftentimes there can be like a spiritual link to pain as well, which I've been sort of starting to understand a little bit more as I work with more people with chronic pain. But I just, just wanted to get your thoughts about sort of the unseen. Is that like repressed stuff that's happening in the brain? Is that, just kind of that side of things, literally working with moving energy. And what are those repressed emotions? Sometimes we'll move that pain. And I've had people have relief from pain from working on that level, which is really interesting to me because you're like,
Yeah, I mean,
I have a really, oh, go on, Diana.
I was gonna say, I think that's beautiful, and I would not consider myself an expert in energy work or like the spiritual realms and connections with pain, but I definitely believe in that. And in my training as a somatic experiencing practitioner and working with trauma, like often people who have trauma are going to be experiencing chronic pain, and there's all sorts of trauma, including generational trauma that we've inherited. So I like in that sense, like that's the lens I might come at it. This training, we're not necessarily going into trauma resolution, more about creating overall safety in the nervous system and specific ways to do that, which I think absolutely can support people with chronic pain. So, and I'll share some book recommendations with you, and I would love to get your recs as well.
Yeah, I guess on that tip is that generational trauma piece and the somatic how the pain shows up in a somatic way when there's a generational trauma. You know what I mean? How that
Yeah, I mean, often, well, I'm gonna pin this just because I don't want to
Okay.
get too sidetracked
Right,
for
yeah.
our topic, but I'm like, oh, yeah, let's, I
I
do
really
want
want to look into that a lot more. That's, I guess, the kernel of my question that I finally got to. Thank you.
yeah, I will just say
Uh,
it fills up physically, like it does. So,
I have only a tiny response to that, which is that I don't know at all. But what we do know is that spiritual fitness, which is a connection to some sense of things being bigger than you, or some sense of purpose, a sense of connection, enhances both health outcomes and joy and positive life experiences. So there is something in there for sure. Yeah. We're gonna, oh, go on. Oh, yeah. So we're
Oh,
gonna
I
zoom on. Oh,
understand.
yeah, no, go. Okay. So I'm going to share my screen. I'm doing a very short little section today on two aspects of pain science that you may or may not have heard of. And one is, so Diana has talked a lot about the ascending signal, and there is also the descending signal. So the gate control theory of pain is one that is not currently absolutely proven, but it has been around since, ooh, I can't quite remember. It's either this is terrible, the 60s, 70s, or 80s. I'm giving you like a 30-year window, but it is so well established that it is the background of many other scientists' exploration into pain. So while we can't say that this is definitely the case, it is widely accepted by neurologists, the gate control theory. And this is primarily a descending, essentially interruption of signaling. So as Diana has explained, there is no afferent, which is the movement from the outside to the brain, for example. So you stub your toe, there's an afferent signal to the brain. There is no afferent signal of pain. There is an afferent signal of threat. And I love that nociceptors, which give you that signal of threat, I love that they're called nociceptors, because what they're telling you is no, don't do that again. So my favorite example for nociceptor action is you bang your toe against a wall. An afferent signal travels up to the brain. The cognitive areas of your brain and some other areas analyze that signal and they go, was that a good idea or was it not? And when they realize that it could cause significant tissue damage, it sends an efferent signal out. And I like to think of, remember, I know Diana has a different route for remembering afferent and efferent, but I think of efferent like effluent flowing out. It's pretty gross, but an efferent signal back from the brain to the source of the danger, and that we experience that as pain. So obviously I'm repeating to a degree what Diana said, and I'm a great believer in hearing similar things from different voices with different languaging can really help to, and then for you guys to write down your own way of describing this for yourself is a really great way of remembering. There are a couple of theories around the gate control theory. One is that the nociceptors are smaller and slower. To my knowledge, the slower bit may not be as significant as the whole idea of what happens here. So this little black dot, but just inside between the zigzag line, the blue line, and the black dot, just here in an area called the dorsal horn of the spinal cord. That's more significant possibly than the speed and size of the nociceptors. So I have read two theories about gate control theory. One is that the signal on this nociceptor is slower than the signal from a somatoreceptors, which, for example, experience touch. So I'm sure that if I unshared the visual, but I'm going to keep it up just for speed, and asked you, what's the first thing you do when you bang your elbow? you rub it, right? Your hand goes there. And then what do you do if you have a period pain? You seek out a hot water bottle. So you get a warmth signal, a signal of warmth. So one of the theories about the interruption of the pain signal, which is where the gate control, like a gate is closed on that signal, is that this signal from the somatoreceptors is faster, and you can flood the brain with that. And this signal here along the nociceptors, you can see I've made it get paler. It's like it loses strength. And so we get less sense of threat to the brain. So we rub our toe, we put a hot water bottle on our body, the brain feels less threatened because it's getting some very clear other signals from that same area. Another theory about it is that this is still the somatoreceptor, that once it jumps from one end of a neuron to the beginning of another, it somehow magically sends out a little tributary, this tiny line here, which is called a collateral. And that activates a tiny neuron that's so small that I couldn't draw it here in this illustration, that I must say I'm rather proud of having made myself on Canva. And this inhibitory neuron in here secretes a neurotransmitter that closes the gate. So it is either about flooding through speed, or it is about a neurotransmitter here that is offered by this neuron that basically stops that signal going past. I love it. I was explaining this to somebody just before the call, and the question was, well, why would the neurology naturally try to interrupt a nociceptor signal when nociception is important? It tells us what the threat is. And I didn't have the answer. I don't know what the answer is. Once we get up here towards the brainstem, we're talking about the beginning of also, this is where the next theory of pain control or modulation occurs. So we get a bidirectional response from the brain that again can help to decrease nociception. And you can imagine how important it would be for the neurology to be able to access decreased nociception for chronic pain, for example. So all those examples that Diana is talking about people who've had pain for a long time, if, as is Diana's big job, if we can help the threat bucket to be less overloaded, then the nervous system might be able to create these interruptions of pain a little more readily. So what can we do in class? Let me stop the share there. I will be going back to another slide. We can think about touch, pressure, vibration, and stretching. All of those things will stimulate somatoreceptors and mechanoreceptors, which also are receptors that feed the brain with a lot of information that the brain likes. We've already talked about the brain really liking to have a good somatic sense of itself, a good proprioceptive, a good map, a clear map. So I would be adding self-massage to your classes, or touch of consented touch in, say, a restorative pose or in Shavasana. Just a note on consent of touch. I have learned quite late in my career that we should ask people to opt in, not opt out. So if you have a group and you're saying, I'm going to offer a little foot massage here, hands up if you don't want me to do that. If you try in a group asking people to say they don't want something, they will be checking to see how many people else are saying no. And if no one else is saying no, they won't say no. They don't like saying no. So what I do is I describe exactly the touch I'm going to give. And then I say, if you would like that, raise your hand. And you may be surprised at the number of people who say no. So there is I don't know if it's a theory, and Diana, you may be able to help me, but we've talked about homunculus and the different areas of the brain having bigger or smaller maps. Areas of the body having bigger or smaller areas of the map in the brain. And a theory that I learned when I trained in neuro stuff was that we have 5 areas that have a lot of more neuroreceptors than other areas: the jaw, the spine, the hands, the hips, and the feet. So I go big into helping people maybe self-massage their hands or their feet, which are nice and low trigger for most. Some people will have a trigger with hands and feet, but for most, it's very hard also in a class to massage your spine. So we're going to do a lovely little hand meditation for a couple of minutes, and then I will jump back to my last slide of the evening. So just take a moment you can look away from the screen, and you're welcome to have your eyes open or closed. And you don't need to hold your hands in any particular way, but just notice the sensation in your hands. You'll probably notice that as you notice, that the sensation increases or changes. And thinking back to Diana's exercise, I think 2 weeks ago now, where we did the ABC all down the side of a page and we created names, different adjectives to increase our interoceptive vocabulary. Could you see if you could find subtler, more fun, playful, explorative, curious names for the sensations you're feeling in your hands? If you're triggered by hands, maybe choose your feet. And if that's triggering too, is there an area of your body that you could check in with? And if not, maybe you're comfortable to just watch your breath or to open your eyes and look around your room. And then if you're comfortable to do so, could you begin to give your hands touch from each other? So bring the hands to connect with one another in some way. And notice that experience, maybe just still for a moment. Notice bits that feel harder, softer, warmer, cooler. And then begin moving one hand against the other. If at any point you want to stop, please stop. And move it in any way you like. And imagine that you are using the hand that's moving to explore the surface of the hand that it is moving against. You can use your fingernails, your fingertips, your knuckles, the back of your hand, your palm. And it's like maybe if you were unsighted and you were using touch to try and see what this thing is and the detail of it. And then you're going to do a really difficult job. You're going to try and only or primarily notice the experience of the hand that is receiving the touch. It will be very tricky. Do your best. You can probably feel your rusty brain cogs whirring, trying to isolate that part of the experience of your brain, of your hand receiving. You might find it's easier if you don't use your fingertips because they're so sensory. And then when you're ready, just allow yourself to turn that into some different kind of pressure. And you can offer it to both hands. You can give each hand a little treat. And just offering maybe tickles, squishes, whatever feels good. Keep breathing, let the jaw stay soft. Your eyes can be closed or open. And then let's take that, just if you're comfortable, to massage the hinges of your jaw. And as we offer these pain modulating practices, we are not fixing the issue. We are essentially choosing to distract and to flood the brain with something a little nicer. You might choose to massage your scalp. If you're a face yogi, you might have some little techniques that you'd like to add there, either for yourself or in your teaching. And then when you're ready, offer yourself a little yawn stretch. Especially a yawn. Let the yawn come in. Really nice for the nervous system to yawn. And then come back to the real world. That's part of the real world. Not one we get to inhabit very often. Oh, I could just stay there. But we shall move on. And just wanted to remind you, actually, before I move on, that this is, as Diana said, nitty-gritty. You're not expected to remember this. And I'm fascinated by it. I hope that it just gives you a background for why you're going to choose to offer more practices like touch and warmth and blankets on people and that kind of thing. And then this next one is going to help you maybe see why you might choose to add more or think more about the neurotransmitters, the feel-good hormones. So this is another route, and this is absolutely based in proven science, which is descending analgesia. So this is where we can actually quite consciously choose to work towards supporting our brain, supporting our nervous system to experience less pain. Now, it's a very complicated map there. Please don't get overwhelmed by it. So what influences descending analgesia? The descending analgesia is basically a signal from the midbrain down, and Diana will talk about the brainstem a lot, and on another week, I think, or this week. It's a descending signal that stimulates certain areas to secrete more particular neurotransmitters that have a analgesic effect, that they're painkillers basically. So the afferent signal from the nociceptors, so the signal up goes to various brain regions, which contribute to control the motivational behavioral responses to pain and the emotional response. So the signal is going to both cognitive and emotional areas of the brain, which are making the decision about what the response is going to be. So there is cerebral input. There is my thinking brain, the bit of me that is conscious. And there is also information going to the sensory cortex, which isn't as conscious. So that's that hairband across the top of the brain, the sensory cortex next to the motor cortex. So these signals from the nociceptors tell different brain regions if they need to send analgesia. Is this something I need to dampen down? Is it too much to handle? And as I say, they start around the midbrain, which is part of the brain stem, and they start to stimulate nuclei, or core bits of neurons rich in norepinephrine, which is adrenaline, and serotonin, which is that lovely softening, soothing neurotransmitter. And the interesting thing is they come down here again. I hope you can see my cursor, where the green arrow and the red bit here meet. So the same place as the gate control theory. when they get to that spot, these norepinephrine and serotonin, that inhibitory neuron, which lies there, which we talked about in the gate control theory, releases morphine like chemicals. So opioids, endogenous opioids. Endogenous means something made in the body. Exogenous means something that you put in from outside the body. And they are thought to inhibit the signals going up again. So they're slowing the nociceptor signal again. So it's like this wonderful circular effect that actually, even though we don't know for sure about the gate control theory, the idea of these working together is really quite likely. We're really, I mean, the wisdom in the nervous system is quite spectacular. And so how can we support the descending analgesic effect would be optimizing serotonin in the body, and the nutrition section of the training that is already up there as a bonus talk will give you some idea about serotonin optimization through diet. But also, I think there's a section in the manual, and if there isn't, I'll talk about it. There are lots of other ways to stimulate the production of serotonin. Also, clear input from the body to enhance for the body to enhance that sensory cortex function. And then the cognitive part, sorry, I'm just going to stop share there. So the clear input of things like the hand massage can also stimulate this sensory cortex to make it more awake and more accurate. And then movement will stimulate the motor cortex. So any kind of movement will help. But then the cognitive piece is really important. This is such a big thing for yoga, is telling yourself, I'm okay, I'm okay, I'm okay, I'm okay. So this is another example of the biopsychosocial quality of pain management, that even if we have a broken leg, we can modulate the pain for a bit. And it is often temporary. And of course, it's not fixing the issue, but it may give us the freedom to move that Diana was talking about, that Trisha was talking about, etc. And Miriam as well, that we're not creating that fear around. Yeah, so I guess what I'm trying to say is the cognitive piece is important too, and that's something I think we do quite well in yoga, that essentially talking yourself down. And the spiritual aspect of that is satya. So what is the true nature of what I'm going through? And can I actually see things for what they are? And that might help me to be less jangled by them and adding to the difficulty. Passing over to you, Diana, my friend.
Great. Wonderful. Should we take like a 2-minute bio break? Do we?
Sounds like a good 2-minute water in, water out. Let's come back
Bio.
at 3 minutes past approximately.
Gonna jump right back. I'm just gonna jump right back into things. Just a little bit more of the nitty-gritty. This is a graph. It's actually kind of an old graph from 2007, but I really like it, and it's adapted from Lorimer Moseley. And if you are in the pain science world, you've likely heard of his name. He's definitely a world leader on pain science and definitely ahead of his time, as far as what we understand. So this image really describes quite well the process of pain, and it goes back to that model of inputs, integration, outputs, that Neve also really shared about, of like, oh, like how dangerous is this really? Like, how is the brain interpreting things? So essentially, once we're getting that 11 million bits of information, the inputs, it goes up to the brain, and the brain has to filter all of that information very, very quickly to decide what to do next. And its number one question, once it's getting this input, is how dangerous is this really? How dangerous is this input really? And so this box is some of, not exhaustive, but some of the filters that the brain uses. And I think it's helpful to understand. So, of course, the sensory input from the body is just, I think Neve really talked about that a lot as far as the homunculus and all these things. But we have, like, how dangerous is this sensory input really? Like, so that's just one, I think that's the most easy to understand. Um, Previous experience, right? So this is, for example, the stubbed toe example. Let's say in the past you've broken your toe and then currently you stub your toe, so you get the sensory input and the brain is like, how dangerous is this really? And it's like, well, remember that one time when you broke your toe, this is really dangerous. So you might experience a higher level of pain just because you know it's like the same, it reminds your brain of something you've previously experienced that was really bad. Cultural factors. So this is actually, I think, what Trish was talking about a little bit, like the family, like your family culture a little bit. You sometimes with the children, for example, if they run down and if they run and they trip and they fall, sometimes they'll look up to their family, and based on their family's response, their family's reaction, if you have a parent that's like, oh my gosh, like that's really bad that you fell, or like they show a lot of fear or have a lot of fear around pain and injury, like the child learns that from their cult, like from their family culture. I think there's also a bit to say around gym culture, the no pain, no gain. So there's a lot of stories and around, you know, when you're an athlete and you're training and you're at the gym and it's like you want, there's this thing of like, oh, no pain, no gain. And so you might be experiencing some pain while you're doing your training, but this culture of, oh, well, that's a good thing. Like sometimes people will bypass the pain they're experiencing, or they won't experience it as much. Um, so cultural influences will help our brain answer this question, how dangerous is this really? Our social and work environment is another huge one. There's a ton of research on poor work environments and poor social environments and increased pain. Now, it could be a bit of a chicken and an egg. Like sometimes poor work environments do actually create more poor sensory input. But also, if you think about pain as an output of the brain, there's a lot of like if you wake up really sick or in pain, then it's likely you might have to skip work, right? So like sometimes pain can help us change our behavior. So there's a ton of studies on poor work environments and a high correlation to higher pain levels and pain experiences. Um, Expectations about the consequences of pain. So this one to me it's sort of like if you play guitar or are a musician and that's your biggest stress relief or even your job and you love playing guitar and you hurt your hand or bang your hand against something, you might fear a higher consequence from that sensory input than somebody who doesn't play guitar, right? So there's how your brain interprets the expectation about the consequence will influence or could influence your pain experience. And then, of course, our beliefs, knowledge, and logic about pain itself. So, even just knowing more about how pain works can help shift your pain experience. Knowing that, oh, my tissues, like my body might not be, like, yes, I'm experiencing pain, but it might not be tissue damage or whatever. Like, just knowing how pain works is going to influence your pain experience. So, teaching people how pain works and how complex it is and how like it, like it doesn't necessarily mean your life is over, or it doesn't necessarily mean you can't do yoga anymore or this thing anymore. Like knowing that can be extremely helpful for somebody's pain experience. So, um, as your brain filters all this information that's coming in through it, based on the question, how dangerous is this sensory input really? And if it decides it's quite dangerous, it's going to produce an output of pain to help change your behavior. So I'm going to stop screen share a little bit just to share this. I like sharing examples. It helps me understand things better. So let's say you are walking down the street and you trip and you roll your ankle. So most people, like your brain is like, okay, I had a quick movement of my foot. I'm getting all this like this potential threat reception up to my brain. And my brain's like, wow, I should like, was really bad. This is really dangerous. I should not continue to walk on it. Right. And so you start to kind of limp away or like have somebody help carry you away so that you're not putting a lot of weight on that foot anymore, and your ankle is experiencing pain so that you don't walk on it and continue the tissue damage, right? And like that kind of makes sense. But let's say the same exact situation, you are walking, you trip and roll your ankle, and as you trip and roll your ankle, you also see a car coming towards you really quickly. So your brain is like, well, the ankle isn't very important anymore. Like that's not super dangerous. That car coming towards me is dangerous. So you might not feel as much pain in your ankle so that you can quickly run away and get out of the greater harm's way. So these are just examples around like your brain is always taking in its context, and what might hurt somebody based on their filters and their exact context they're in might not affect somebody else the same exact way. And then I have one more thing. I'm a broken record here, but it's amazing to get different things. So this image is of the threat bucket. And maybe a lot of you have heard of this, but it's pretty big in the pain science world, this concept of the pain bucket. So the bucket is essentially our capacity, like our brain and nervous system's capacity. And all of the information it's receiving that is a potential threat to it goes in the threat bucket. So any possible thing that is a potential threat goes into this bucket. And that could be the relationship. Maybe you're in a fight with your partner. Maybe you have some vestibular issues. Maybe you have some high stress. Maybe you didn't sleep well. Maybe you have some poor nutrition stuff going on. Maybe there's some systemic issues that are going on that are creating threats to you. Maybe there's some unresolved trauma in your life that is also in your body. Maybe you have some whatever, like you get the point. There's all sorts of things that are coming at you at any moment, and you have a capacity for it. And once you get past a certain threshold, that is when your system will start to produce a pain experience. So, as a practitioner, so what this is basically not saying is that your poor relationship causes pain. That's not what it says. Or your vestibular issue is causing pain. That's not true. Or your poor nutrition is why you're having pain. That's not how it works. What this is really great at showing is like all these potential threats get put into a bucket, and at a certain point, we are going to, once we get to our personal threshold, we're going to have some overflow, and that could be pain, because pain is a great way to change our behaviors in the way that our brain perceives we need, which is we need to protect ourselves. So as practitioners, we might not be able to change all of the systemic issues that are going on for a person. we might not be able to really do some trauma resolution work for them. But what we can do is work on some of their movement patterns. And once we can work on some of their movement patterns, wow, their threat bucket lowers. Like we're taking that out of their threat bucket and lowering the overall threshold. Okay. Um, we might not be able to fix the relationships, but actually in a lot of yoga, there's ethical guidelines like the yamas and the niyamas, and that actually does help our relationships. And by helping our relationships, we can reduce the overall levels of threat. And that can actually improve people's pain experience. So the last thing I'm going to share here, and this is where I'm really, one of the ways I'm really passionate about is, so how can we help take threats out of people's threat buckets? Like what can we do? And we work within our scope, right? If you have the scope to help do trauma resolution, do that. If you are working in like a civic role, or like you want to work on the systemic issues, like to me that is trauma resolution. To me that is also helping people's pain experience. But in your profession we have to work within our scope, and we absolutely can help people's threat bucket, lower people's threat buckets, and help their pain experience. And in neurology, when we study the brain's systems, there's what's called a neural hierarchy. And I know hierarchy is like not a cool word because we like non-hierarchy and all that, and I agree. And some hierarchy is just here. And of course there's nuances, and of course there's going to be like tons of examples where what about this or that, like yes. But overall in neurology it's known that your brain has a neural hierarchy, and at the top of it is your visual system. So it is a system that your brain has, that it depends on to keep it safe. And you can think about this like if you hear a noise, you look, like what was that noise? You look to see what it was. Um, if you, right, and of course, like if the room is dark, you're not going to be using your visual system to keep you safe. So like there's always examples of how this might change. But as we look, I think in 2 weeks, we're going to do cranial nerves and eye movements and all this stuff. So we're going to be really working with the visual system. But and I'll go over some really fun facts about the visual system later. But I want to give you this broad brushstroke. If you can support people's visual system, that is taking a huge chunk out of their threat bucket, and that will have a huge impact on their pain experience. So you might not know if your right eye doesn't see as clearly. Like we don't think in those terms, like, is my right lateral rectus muscle working appropriately? Can I see clearly in the right quadrant of my visual field? Like you might not consciously know that, but your brain does. Because your brain, if you can't see very clearly in the upper right quadrant of your visual field, then anything that's over in your right quadrant is going to appear more threatening to your system. If you can see more clearly, or if your eyes can go to that area with more efficiency, then your brain is like, oh, that's not as threatening to me. Like I know what's over there. I can see it quickly. I feel safer. So as we work to improve people's visual systems, we're gonna really take a lot of potential threat out of their threat bucket, and that often improves their pain experience. The vestibular system is the second on the neural hierarchy. Some neurologists will argue that the vestibular is first, even over the visual system. And the vestibular system is often very directly linked to our eyes. So you'll see some neurologists, or if you read a lot about this, like you do see some really interesting discussions about that. But your vestibular system is essentially your inner ear and it's your orientation to gravity. So it's how you know what way is up or down or um, where you're going. Very important for your body to feel safe for the next few moments. If you don't know what way up is, it's very challenging for you to get out of any threatening situation. Um, and then, of course, the proprioceptive system is also of high importance to the brain, but it's considered less important than the visual system. And one way I like to talk about that is, for example, if you, let's say you don't have, I'll use a client of mine. He is partially deaf in his left ear. And so because of that, his head, like he often walks around with a very slight turn of his head to put his good ear forwards. He doesn't do that consciously, right? It's not a conscious decision. It's just how his brain has oriented. So it's changing his proprioceptive posture. He's changing where his body is, even though, then there's his head is turned. Well, then his neck muscles are constantly shifted. They're not centered. And so then he has this like compensation twist in his spine and so on and so forth. So his brain, because he needs his ear, his vestibular system to be oriented this way to hear what's going on more, it's his brain is doing that automatically and not really as concerned with what that's doing to his posture, even though it's causing him pain in his body, because it's more important to stay alive for the next few moments for him to know, to be able to hear more clearly with his good ear. So these are just little things that we can begin to see. Let's see. Nicole, will you, so she asks, is this pain info referring to acute or chronic pain or both? I'm gonna go ahead and say chronic pain. I do think acute pain is, we have to treat acute pain a little bit differently. Yeah, so more chronic pain. Okay, so let's try, I'm not teaching eye exercises yet, but let's do an eye exercise together. This will be like a preview for a couple weeks from now. And then I'm going to break you all into small groups and you'll have some options of what you feel inclined to teach or offer to each other. But first, let's all, I'm going to say stand, but if you prefer to stay sitting, that's completely fine. And if you're like, oh, I kind of want to lay down, that's fine too. But if you're like me, you're ready to stand. So we're just going to do a simple eye circle. This is my go-to eye exercise. And we're going to start with an experiment. And we're going to look at neck rotation. So you just want to make sure you're standing or sitting exactly where you know you're going to be later. So just take a look to see what the mark on the floor is or where your chair is so that you can do the same thing in a little bit. And then just stand or sit comfortably tall and look over your right shoulder and just notice how your neck feels and what's easily in your field of vision. Okay. And once you have that, look over your other shoulder. Notice how your neck feels. Notice what's easily in your field of vision. And then come back to center. So that was the before. Now we'll do 3 eye circles each direction. I want you to picture a beach ball, so not the biggest circle, maybe the size of a beach ball, and your face is going to be the center of the circle. Left hand to your chin, right arm out. You can look at your fingernail. If that's too small, you can grab a pen or an object. If you're wearing glasses, you can do this with or without your glasses. Okay. But you're going to look at your object and bring it to the top of the circle and then trace 3 circles clockwise with your finger. And you're tracking your finger with your eye. and just breathe normally. I don't care as much about speed, but try to be as accurate as you can. And after the third circle, once you get to the top, you can pause, close your eyes, blink it out for a moment. No rush if you're finishing. And we'll go the opposite direction. So I'm going to switch arms. It's up to you, but right hand to chin, left arm out. Bring your object to the top of the circle and do 3 counterclockwise circles. And you're tracing the circle with your finger, but tracking it with your eyes. If there's a point where your eyes skip ahead or lag behind, just try your best to keep your eyes on that moving target. And breathe. Once you get to the top of the circle, you can close your eyes, shake it out, do whatever you need. No rush to finish. And as you are done again, no rush. Take your pause if you haven't yet, and you're in the exact same spot. And you'll turn your head to the right and notice if there's been any shift. And other side. And then come back to center, and then just put in the chat if you had an improvement, if you stayed the same, or if you got a little worse. Improved, improved, improved. Significant.
This is my favorite part of this training.
A little improvement. Improved both sides, one more than the other. Less rigid feeling. A little bit worse to the left. Great, I love it. So, small amounts of improvement both sides. Yeah, so there's really only 3 possible outcomes. You improve, you stay the same, or you get worse. So it's kind of cool. Most people will improve. And we're gonna go over all of this a lot in a couple weeks. But if you improved a little bit or a lot, it's a sign that your brain, you just took a big threat out of the threat bucket. And you know that you're less threatened because in addition to pain being a protective output, muscle tension, constriction of movement is a protective output. That will usually show up quicker than a pain improvement, but sometimes pain reduction is instant as well. But you'll know if this worked immediately if you improved. So if you got greater range of motion, your brain is like, I don't feel as threatened, so I'm going to not hold as much tension in my movements. So you'll have more fluidity of movement. If you got a little bit worse, there was something about that your brain was like, I don't like this. You just added a tiny little more threat into the threat bucket. And I consider that great information to have. And so how I would work with that often is, because we want your eyes to be able to track a moving object. That's a really important skill. So if there's something about it that was threatening to your system, then I often will do regressions, maybe less repetitions or something like that. We're not really training in this training to do rehab work. What I am more interested in is getting people to have things that their brain likes that takes threats out of the threat buckets. But if you know certain eye movements are threatening to your system, that's really good information to know. And you're like, okay, I'm not going to do eye circles before a big meeting. Like that would not be good for me. But if you have a meeting and the eye circles work, like do some eye circles before you go into the meeting. So even if you got a little worse, to me, that's still really good information to know. And what we want to do is find specific movements in your visual system that support your brain. Let's see. Some great questions. Why do we put our hand on our chin? Yeah, Meg answered that. To keep your head steady. Very often when people are doing eye circles, I'm exaggerating, but it's like you move your head. And the idea is to keep the head and the neck still so you're really targeting the muscles of the eyes and the nerves that go to the muscles of the eyes. So it's not horrible if you move your head a little bit, but we are just trying to be as targeted as we can. So we have a half hour, which is great. And what I would love to do is to break up into pairs. Actually, we have time to do 2 small groups, which is even better. So the first small group, what I want you to do is teach each other this eye circle. I know I didn't go over cueing. I know I didn't go over all the questions. We're learning. Okay. I believe in you. You're all professionals. So I'm curious for you to just get it out, teach somebody without knowing it perfectly, just to get that repetition in. So I'm gonna break you up into a 5-minute small group with a pair, and each of you will have about 2.5 minutes to teach the eye circle without having too much guidance as to how to teach it. Is anyone brave enough to say if that makes them extremely nervous? Miriam, yeah, my heart is with you. So we can, yeah. Yeah, it's nerve-wracking to teach something new when you're not good at it yet. It's scary.
It is. I'm just we'll be taking a sec to excuse me, organize this because there's a couple of people, one person who can't join the breakout, so I just need to do some messing around.
Yeah. And the person who got a little bit worse, if you don't want to do eye circles again, because you're like, well, my neck tightened up, so I don't want to do them again. You can still be the body, just don't do the eye circle, but like let the person still teach the exercise, just don't do it. Because this is ultimately about learning how to teach. So, but I also want you to honor your own nervous systems and don't do something if you know it's not good for you.
Okay, so I've made the rooms, and Pippa's saying that her connection may go if she turns on her video. So I've put you, Pippa, in a room with someone who doesn't always join the breakouts, and I think apart from that we might be okay. If you find you're in a room with nobody, I should see that, and I will be able to try and mess it around. But if you're in a room with nobody, just wait a sec, and I'll find a way to get someone to you. What should the recording viewers do?
Yeah. So if you are watching the recording, you get to teach it to a loved one who is going to be a good student to you. And if you don't have that or don't feel like it, record yourself doing an eye circle. That way you get the practice of saying it out loud.
Excellent.
Welcome back. Curious if anyone wants to share their experience of teaching an eye circle.
Did everyone get to do it?
Oh dear.
No, we only got one person to do it. Yeah.
Oh,
So I'm
okay.
wondering, was the time? It certainly wasn't 5 minutes. Didn't feel like 5 minutes.
Oh, really? Yeah. No, I have this. So I try
Oh,
to keep it-
Diana, that's American time. You know, we Irish have to do, we in Ireland have to do introductions and who are you from? And
Right. Oh,
yeah,
yeah.
no.
Okay, too
American
quick.
time.
Noted, noted, noted. Well, we are going to be going back into another breakout room in a little bit, so you'll have a choice for the second one if you want to teach. If you didn't get to teach, then you can use the second breakout room to teach. So, yeah. I know I'm like chip chop chop, let's go.
Yeah, Diana
Well,
scares me with the breakout rooms. She like closes them without any warning. I'm like, oh, I'll just give them another half an hour.
Irish time.
so for those who did get to teach, how was that? Seen some, yeah, Jasmine?
I have been going through your workbook. So I feel like I've already, and I think told you this on Instagram, I've been starting to teach my family. And what I find so fascinating about teaching, like was mentioned in this course, it's almost like you can never truly learn something until you teach someone else and you take in their perspective. Is there's always experiences that I might not ever considered because I look at them through the lens of my own experience and body. So things like wearing glasses or not wearing glasses and how that might affect our experience is not something I would necessarily consider unless I teach it or unless I, let's say, broaden my lens in which I experience things, and that might be through teaching. So it always fascinates me how much I seem to know my own, I don't know how else to say it, my own experience versus how someone might enlighten me with theirs, if that makes sense.
Yes, thank you for saying that because, yeah, you only have your experience.
Mhm.
And I mean, I remember this when I first started yoga. I loved yoga, so thought everyone would love yoga. And when they didn't, I was like, well, I just must not be teaching it good enough because if I did, you would love it because yoga is amazing. Um, eye circles are similar, that's why I love seeing this training and asking like I love that somebody was like, yeah, it made me feel tighter. That's important for us to know as teachers. That's the same thing can be completely different. And yeah, the more you teach and the more how you see people respond, the more you'll feel comfortable with um, the little outliers that pop up here and there. Thank you.
And there's a wonderful thing about when you've been offering it to a variety of people, is that at some point you get to a point where no one's experience is, or not no one's, but everyone's experience, you've heard it before. So you as a teacher don't get sideswiped by, oh cripes, what do I do about that? So, in my menopause teaching, just, I now have heard pretty much everything. And I remember, I think I said this to you guys at one point during the training, that I have one student who feels nauseous for any brain stuff that I do. And so I asked Anna, what do I do? She gets nauseous moving her hands. And she said, let her imagine it instead. And I just didn't have a template for that. But now if I meet someone else, I'm able to say that to them. So it's, I think that's a really big part of teaching this work, particularly, folks, because it is complex, because most of us have never met it before. And certainly it took me a couple of years to get comfortable using any of this kind of stuff. And your students will be like, what is she doing? Just to be patient with yourself about when and how you start to introduce this work, because it really is, it's quite the thing. And give yourself time to get used to it. And your own experience is a brilliant place to start. And family and friends, as you're doing, Jasmine, as well. Yeah. Miriam.
Had the experience of being taught, and one of the things that I thought was lovely that Saffron did was she cued my breathing. And so just as we were starting, so I felt very calm before it ever started. And I just found that was effective. It was a very familiar cue to me, doing something that wasn't so familiar. Does that make sense?
Yeah, I love that. So start like your teacher offered you something familiar
Yes.
before she introduced something novel. I love it. And that worked really well. So I want to do breakout rooms again, and I'll have them be a little longer this time. 6 minutes, not 5. and maybe 7. And so my hope, if you didn't get a chance to teach an iCircle, you have a choice. You can teach an iCircle, or this is the prompt for the second group, which is explain the threat bucket to your partner. So this is a very amazing educational concept, and you can use it to help so many of your private clients, even your public classes, and getting the words out of your mouth is going to be helpful because concepts make sense up here. And then once we start talking about it, it can get a little word trippy. So give it your best shot, explain what the threat bucket is, or teach an iCircle. So we'll have 6 or 7 minutes in small groups to do that.
And I'm going to do the same breakout rooms in terms of the people you're with so that you can make that choice about teaching the eye exercise if you didn't get a chance. You never know, you might be able to do both. Okay, Sarah, thank you. Are you going now, Sarah? I might have to reassign. Okay, Sarah, lovely to see you. I just have to reassign there. Where was... So what I might do, is put you in room 7. Sorry, folks, to be talking as I go. Where's room 7? Room 7. Did she go? No. Oh, sorry, I exchanged. Move to. Sorry, folks. Room 2. Okay, this should be okay. Fingers crossed. If you get lost, just send a message or, I don't know, shout.
Yeah, and if you are watching the recording, what you can do is teach an eye exercise or teach the threat bucket to, again, a friend or family member, or do a voice memo recording just to get those words out of your mouth, and teach what the threat bucket is.
Yes, exactly.
Yeah. So is there anything else that would help? You could give me a little nugget, just a little bit about helping to understand the threat bucket.
Yeah, well, I'll actually pass that to the group.
Okay,
Because
great.
maybe you all had an amazing conversation that could help Pippa with her question. Any
Yeah,
insight?
so what I would love to hear, what would help me, because I missed a lot because of my connection here, is if any of you have just got a few little nuggets to help grasp the concept of the threat bucket. That would be really cool. Thanks.
Anybody come up with some fab language or some? Yeah, Miriam?
I think what struck me was that I don't know that we use the word threat that often. We talk about feeling safe, but we don't necessarily use the term, at least we don't here on this part of the world, girls. We wouldn't, and threat is to me quite a loaded word. And so I found that interesting because I was doing the talking, no surprise there.
Yeah.
But I found that interesting, and I found myself trying to work around it rather than use it.
I honestly think that's so wise, Miriam. And when I learned about the threat bucket model, I had a whole, I'm trained to work with people who have trauma, and I'm a somatic experiencing practitioner. And I was like, oh, so to see every single thing in somebody's threat bucket can feel overwhelming to me, actually. So, which is threatening to my nervous system. So I really feel like that's a wise approach, is to talk about it in a way with language that feels safer to use. So I think that's brilliant. Yeah.
Trisha?
We were talking about using the word overwhelm, and we're also talking about not just using the visualizing a bucket, which is great, but some people don't have skills with visualizing things. We're trying to figure out a way to explain it in another way. So I was thinking, if you have a little bug bite on your hand and you have a little itchy spot, You know, that's one thing in the threat bucket, for example. And then if you have something that's taking over your whole hand that's itchy, and then your whole arm, and then this whole side of your body, and I have poison ivy covering my entire body. And so that's kind of like what the threat bucket is like. The whole bucket, you get overwhelmed, your whole body's itchy now. So by being able to remove some things, it's like, okay, can I do an oatmeal bath? And maybe that stops my chest from itching. And can I put some ice on my arm? And maybe that stops my arm from itching. And by using these different avenues to reduce some of that overwhelm of the body, of the brain, of the mind.
Yeah. Yeah. What a visceral image. Ooh, I love it.
It's making me itchy.
Also, I think it's making it, the other has so many big issues like relationships, nutrition, sleep. That to me, Tricia, really makes me sense that panic of being under threat. So thank you.
Yeah, so I want to honor time. I will stay on to answer any more questions, but just to honor time, we will be back next week talking about well, Neve will be here next week talking about pranayama and spiritual fitness.
Lots of other things.
Lots of other things. So if you need to leave, thank you. And if I will stay for a few more questions if you have some. Thank you so much. Homework is, I think there'll be a new quiz. Yeah, there will be another quiz to take.
I'll email everyone with that.
Great.
Brandy.
Hi.
Thanks,
First of all,
Susan.
I just want to acknowledge I'm learning so much. Thank you.
Hmm.
And my question is about pain that appears out of seemingly nowhere. I have somebody that I'm going to see on Monday who woke up in the middle of the night and just based on what I know psychosomatically around the Achilles, it doesn't line up at all. And he woke up in the middle of the night, no strain, no, like, he's pretty conscious of his body. So there was no moment where like, ooh, he stepped the wrong way and maybe this could happen. In the middle of the night with excruciating pain, seemingly out of nowhere, and has been experiencing difficulty walking, has to be wearing a boot, and is basically hobbling around from this seemingly phantom pain that came out of nowhere. And I'm just wondering, is that where I could maybe learn a little bit more about what might be going on in his system or in his brain that may have triggered something like that.
Yeah, I mean, these are the big things. It's like, I have no idea why that happened, especially when there's no direct cause. And this model of the threat bucket can be so helpful. There's other things in neurology that I'm like, oh, I would try this, this, or this, which I can share with you.
Cool.
But as far as like how the threat bucket works, you don't necessarily have to work on his Achilles tendon, and sometimes going directly right into the pain isn't always the best. It sometimes is, but often periphery to center, right?
Sure.
And so just thinking about ways you can support the amount of safety in his system can be a huge boon. Also building relationship to that. And I think that sounds like maybe what the kind of work you do is like building relationship with his Achilles tendon, with his heel. Like, what does the fear feel like in his body? Like, where is he
Like the
most
whole
resourced?
picture. Yeah. But I have no idea, like if he's not conscious that something happened, right? Like that pain is not like a psychosomatic like response to something, or is it, you know?
It could be. It absolutely could be. I tend to shy away from needing to know why pain is present.
Okay.
I don't need an answer. I don't need to know exactly why someone's pain is there. It's here. And so what I tend to notice in people who have pain similar to that is like, yeah, like what happened? They're scanning for what they did, what helps. Like there's all this energy into that to like figure out why. And so part of my job is, okay, let's decrease the overall level of threat in your system.
Yes.
which means decrease the hypervigilance potentially. Like, let's see where you're resourced, where can we get more resource, so that can help decrease the threat level in their system. There's other things we'll be learning like next week with brainstem work, like, or Neve's like descending analgesia effect, like that kind of stuff can be really helpful to start bringing in. Often when I do what, like if I see somebody with Achilles tendon, my first thought neurologically speaking is jaw, like the opposing joints. So Achilles tendon and jaw are often the opposite jaw. Could be related. There's other things that you'll be learning next week, techniques to figure out some of these odd type things. It's a unique way to approach moving with the body, and different approaches, which is kind of fun to bring in, especially when it's like seemingly out of nowhere and that. So yeah.
I
Awesome.
would
Thank-
also, on a physiological level, remind the person and remind yourself of the fascial connection throughout the body, and that if we move our shoulder, we're moving our Achilles tendon. So that you can move the body in many different places, and it will support many different places.
Awesome. Thank you so much. Very helpful.
You could also suggest that he cuddles Saffron's dog that she was cuddling a minute ago, because that'd be really good for him
That's
too.
gorgeous. Can I ask a completely teachery type question?
Yes.
What's the final assessment, or did I miss something about what this practical thing is?
The practical exam is going to be a 10-minute, you'll be teaching for 10 minutes, and there'll be specific requirements that we'll be asking you to do. I forget
We
what
don't
they
know
are.
them yet.
We do know what they are. You've learned some of them. Like one, you'll have to be teaching one eye exercise. You'll have to do one like non-dominant or like a brain activation thing, like the hand flapping, hand
Yeah.
circle. Like I forget.
But we'll be teaching both of us much more about all of this before you need to be concerned about that.
Didn't start practicing yet then.
No, I wouldn't, because
Don't know enough.
you need the foundation.
That's okay. I wasn't sure if I missed it.
I think last week I said that we will be asking for you to look for two certain challenges yourselves, but you don't need to start doing that. It's just
That's
a little,
grand.
internet search
Sorry
that
about
you'll
that.
have lots of fun with.
Thank you so much. I'm kind of overwhelmed with all we are learning. So
It's
a lot.
really important, to remember that this is overwhelming. And I think Diana and I have stated it multiple times. Let stuff in and let the rest of it go. Know that it could take you 2 years to assimilate half of it. But if you choose to go and teach this, you already know more than the people you'll be teaching.
every time I do one of those quizzes, Neve, I think, oh, I know it. Now I know it. Now I've got it.
That's what the quizzes are for. They're not about you getting it right. They're about you using that to go, okay, where are the holes in my information and where can I find that
And
information?
the other thing is, I think, Neve, confession time, I think I have a love-hate relationship with Diana. If I see her doing another exercise that challenges me on Instagram, I'm going, I didn't even get the last one right. They're really good, Diana. Thank you so much.
Patience. Thank you, Pippa. Thank you all.
Thank you, guys.
Thanks, Saffron. Have a great weekend. Bye, Jasmine. Bye, James. Oh. Bye, Jasmine. Thank you for your contributions. Really
Thank you so
interesting.
much.
Thank you so much.